Hello friends, today we are going to discuss the guidelines for ACS which was published in 2023. So, acute coronary syndrome with unstable presentation. The management of the patient with ROS without evidence of ST segment elevation should be individualized according to the hemodynamic and neurologic status. In out of hospital cardiac arrest with initial shockable rhythm and without ST segment elevation or equivalent with and equivalence and without cardiogenic shock, routine immediate invasive uh, in fact, invasive coronary angiography is not superior to delayed invasive strategy based on data from the COACT and the Tomahawk RCTs. Smaller underpowered trials, that is emerge, that is emergency versus delayed cardio coronary angiogram in survivor of out of hospital cardiac arrest with no obvious cardiac arrest, non-cardiac cause of arrest. The Pearl and the COPE have also pointed to the same conclusion. So, based on data from the COACT and Homahawk trial, it appears reasonable to delay invasive coronary angiography in hemodynamically stable patient with a resuscitated out of hospital cardiac arrest without ST segment elevation or equivalent. The decision to perform selective coronary angiography should also consider factors associated with poor neurological outcome and likelihood of ACS. In patients who remain unresponsive after ROSC, monitoring of core temperature and actively preventing fever is recommended to improve neurological outcome. So, recommendations for cardiac arrest and out of hospital cardiac arrest. The PCI strategy is recommended in patients with resuscitated cardiac arrest and ECG with persistent ST segment elevation. Routine immediate angiography after resuscitated cardiac arrest is not recommended in hemodynamically stable patient without persistent ST segment elevation. Temperature control is recommended after out of hospital cardiac arrest patient in patient who is spiking fever for neuroprotection. It is recommended that healthcare system implement strategies to facilitate transfer of all patients in whom ACS is suspected after resuscitated cardiac arrest directly to hospital offering 24/7 PCI via specialized EMS. Transport of patient with out-of-hospital cardiac arrest to cardiac arrest center according to the local protocol should be considered. Evaluation of the neurological prognosis is recommended in all comatose survivor after cardiac arrest. Now, the cardiogenic shock complicating ACS. Early revascularization with either PCA and CABG is recommended for patients with acute myocardial infarction complicated by cardiogenic shock based on the results of the shock trial. While most patients with will proceed to PCI at the time of diagnostic angiography if myocardial revascularization is indicated. Surgical revascularization represents a valuable treatment option in patients in whom attempted PCI of infarct-related artery has failed or if coronary anatomy is not amenable to PCI. In IABP shock trial, intra-IABP use was not associated with lower 30-day mortality. Therefore, in the absence of mechanical complication, the routine use of IABP is not recommended for cardiogenic shock complicating AMI. The role of mechanical vascular device in AMI setting is not well established and large-scale randomized trial are warranted. The extracorporeal membrane oxygenation in therapy of cardiogenic shock trial randomized 122 patients with rapidly deteriorating or severe cardiogenic shock to either immediate implementation of a VA ECMO or initially conservative strategy. Immediate implementation of the VA ECMO did not result in improved clinical outcomes. However, interpretation of this trial is challenging because of 40% crossover rate to VA ECMO in the conservative arm and inclusion of heterogeneous phenotype of cardiogenic shock and the inclusion of crossover in the combined primary endpoint. As a result of this limitation, this trial cannot be adequately answered if mechanical circulatory support device is able to reduce mortality in this setting. So recommendation for cardiogenic shock, immediate coronary angiography and PCA of infarct-related artery is recommended in patient with cardiogenic shock complementing ACS. Emergency CABG is recommended for ACS-related cardiogenic shock if PCA of infarct-related artery is not feasible or successful. In case of hemodynamic instability, emergency surgical and catheter-based repair of mechanical complication of ACS is recommended based on heart team discussion. Fibrinolysis should be considered in STEMI patient presenting with cardiogenic shock. If PCS strategy is not available within 120 minutes from the time of STEMI diagnosis and mechanical complication have been ruled out. Recommendation for intra-hospital management. It is recommended that all hospitals participating in care of high-risk patients have ICU and CCU equipped to provide all required aspects of care, including treatment of ischemia, severe heart failure, arrhythmia, and common comorbid. It is recommended that high-risk patients have ECG monitoring for minimum of 24 hours. It is recommended that high-risk patients with successful reperfusion therapy and uncomplicated clinical course are kept in CCU and ICU for minimum 24 hours whenever possible, after which they may be moved to step-down monitored bed for additional 24 to 48 hours. Discharge of selected high-risk patient within 48 to 72 hours should be considered if early rehabilitation and adequate follow-up are arranged. Same-day transfer in selected stable patient after successful and uneventful procedure is considered. Routine echocardiography is recommended during hospitalization to assess regional and global LV function, detect mechanical complication, and exclude LV thrombus. When echocardiography is suboptimal, inconclusive, CMR imaging can be considered. Now, technical aspect of invasive strategy. Percutaneous coronary intervention. Vascular access timely PCI with concomitant antithrombotic drug has reduced the ischemic risk in patients with ACS. However, this strategy is also associated with increased bleeding risk, which affect the prognosis at least as much as ischemic complication and is associated with impaired survival. Among patients undergoing PCI, access-related bleeding accounts for 30 to 70% of total bleeding events. There is strong evidence demonstrating that reducing access site bleeding event with the use of radial access translate into significant clinical benefit. The largest randomized trial on this topic in patients with ACSR, radial versus femoral access for coronary intervention, that is rival trial with 7,021 ACS patients and minimizing adverse hemorrhagic event by transradial access site and systemic implementation of angio, that is matrix trial with 8,404 ACS patients. These trials have demonstrated significantly lower rate of access site bleeding, uh, access site related bleeding, surgical access site repair, and blood transfusion with radial compared to femoral access. Therefore, radial access is recommended as the preferred approach in ACS patients undergoing invasive assessment with or without PC. However, femoral access may still be selectively chosen instead of radial access in certain patients. Now, if there is a working diagnosis of ACS and if we are going for the coronary angiography and it clears the culprit lesion, suitable for PCI, then perform the intravascular imaging to guide PCI. That it has a class of recommendation 2A and the PCI of culprit lesion. If there is no culprit lesion, then intravascular imaging in patient with the ambiguous culprit lesion, treat as per imaging finding and consider further investigation if required. So intravascular imaging is here intravascular imaging means this intravascular ultrasound and optical coherence tomography. So recommendation for technical aspect for the invasive strategy, radial access is recommended as the standard approach unless there are overriding procedural considerations. PCI with stent deployment in infarct-related artery during index procedure is recommended in patient undergoing PCI. Drug-eluting stent are recommended in preference to bare metal stent in all cases. In patient with spontaneous coronary artery dissection, PCI is recommended only for patient with symptom and signs of ongoing myocardial ischemia, large area of the myocardium in jeopardy, and reduced antegrade flow. Intravascular imaging should be considered to guide PCI. Coronary artery bypass grafting should be considered in patient with occluded infarct-related artery when PCI is not feasible, unsuccessful, and there is large area of myocardium in jeopardy. Intravascular imaging may be considered in patient with ambiguous culprit lesion. The routine use of thrombus aspiration is not recommended. Spontaneous coronary artery dissection is infrequent cause of ACS in general, but account for significant proportion of ACS cases in young and middle-aged females. Pathophysiology of underlying spontaneous coronary artery dissection is different to that of the type 1 MI, and there are some differences in management and outcome. Intravascular imaging. In case of diagnostic uncertainty after angiography, the use of intracoronary imaging with OCT and the intravenous ultrasound has to be carefully considered. Regarding revascularization, conservative medical management, as opposed to PCI, generally recommended for patients with spontaneous coronary artery dissection. PCI is recommended only for spontaneous coronary artery dissection with associated symptoms and signs of ongoing myocardial ischemia, a large area of myocardium in jeopardy, and reduced antegrade flow. In patients with spontaneous coronary artery dissection, CABG is recommended when dissection affects the left main and two proximal vessels. If PCI is not feasible or unsuccessful, and if there are signs and symptoms of ongoing myocardial ischemia. Management of patient with multivessel disease. Management of multivessel disease is in acute coronary syndrome is complicated by cardiogenic shock. Cardiogenic shock may occur in 4% to 11% of ACS patients and occur in complete coronary occlusion. Ischemia-related heart failure, acute severe mitral regurgitation, and mechanical complication are major precipitating causes of cardiogenic shock. Irrespective of mode of presentation, these patients should be transferred as soon as possible to tertiary care center, where where invasive coronary angiography can be performed, supported by specialists with relevant experience. In the shock trial, which compared emergency revascularization with initial medical stabilization in 302 patients with acute MI complicated by cardiogenic shock, 60% had anterior MI and 85% had multivessel disease. Among the patients assigned to emergency revascularization, 64% underwent PCI and 36% underwent CABG. There was no difference in mortality at 30 days, but at 6 months, mortality was lower in group assigned to revascularization than in group assigned to medical therapy. Based on this evidence, immediate coronary angiography and PCI feasible is recommended in patients with acute MI complicated by cardiogenic shock. In patients with coronary anatomy unsuitable for PCI, emergency CABG is recommended. Nearly 80% of ACS patients with cardiogenic shock have multivessel disease. Based on the culprit lesion, only PCI versus multivessel PCI in cardiogenic shock trial, including ACS patient, PCI during index procedure should be restricted to the infarct-related artery. In the culprit shock trial, infarct-related artery only PCI was associated with significant reduction in all-cause death and renal replacement therapy in 30-day follow-up. At 1 year follow-up, mortality did not differ significantly between the two. So patient with ACS undergoing PCI of infarct-related artery with angiography significant stenosis in more than or equal to one non-infarct-related artery. Then it is divided into cardiogenic shock, STEMI, and NSTEMI. If it is a cardiogenic shock, immediate PCA of infarct-related artery, it has a class 1 recommendation, and stage complete revascularization has class 2A recommendation. If it is STEMI, then complete revascularization either during index procedure or within 45 days. That has class 1 recommendation. If it is NSTEMI, then complete revascularization. It has a class 2A, and functional invasive evaluation of non infarct-related artery during index procedure is recommended. This statement also has class 2B recommendation. Patient with the multivessel coronary artery disease undergoing primary percutaneous coronary intervention. Over the past decade, a series of RCT have provided clinical evidence that support preventive revascularization of non-infarct-related artery after successful PCA of infarct-related artery. A pivotal clinical trial include PRAMI trial, CULPRIT trial, DYNAMI 3, PRIMALTY trial, compare acute and complete trial. A systemic review of 10 randomized trials that include 7,030 patients with STEMI and multivessel disease. Complete revascularization was associated with reduced cardiovascular mortality compared with infarct-related artery-only PCA. All-cause mortality was comparable in both groups. Complete revascularization was also associated with reduced composite of CV-type mu MI, supporting complete revascularization in patients with STEMI and multivessel disease. Recommendation for management of patients with multivessel disease. It is recommended to base revascularization strategy on patients' clinical status and comorbidities, as well as their disease complexities, according to the principle of management of myocardial revascularization. Infarct-related artery-only PCI during index procedure is recommended. Stage PCI of non-infarct-related artery should be considered. Complete revascularization is recommended either during index in case of hemodynamically stable STEMI patient undergoing PCI. Complete revascularization is recommended either during index PCI procedure or within 45 days. It is recommended that PCI of non-infarct related artery is based on the angiography severity. Invasive epicardial functional assessment of non-culprit segment of infarct-related artery is not recommended during index procedure. Now, if there is a multivessel disease in hemodynamically stable patient and if the diagnosis is NSTEMI, then in patient presenting with NSTEMI SCS and multivessel disease, complete revascularization should be considered preferably during index procedure. A functional invasive evaluation of non-infarct related artery severity during index procedure is considered. Now, myocardial infarction with the non-obstructive coronary artery. Myocardial infarction with non-obstructive coronary arteries refers to clinical situation when patient present with the symptoms suggestive of ACS demonstrates the troponin elevation and has non-obstructive coronary artery at the time of coronary angiography, defined as coronary artery stenosis less than 50% in any major epicardial vessels. Minoca can be considered as an umbrella term that encompasses heterogeneous group of underlying causes. This include both coronary and non-coronary pathologies, with later included both cardiac and extracardiac disorders. Now, the coronary causes of Minoca is coronary embolism, coronary microvascular dysfunction, coronary spasm, coronary thrombosis, myocardial bridging, plaque rupture, and spontaneous coronary artery dissection. Non-coronary cardiac cause include cardiac trauma, cardiomyopathy, cardiotoxin, myocarditis, strenuous exercise, Takotsubo cardiomyopathy, and transplant rejection. Now, the non-cardiac cause include ARDS, allergy, hypersensitivity reaction, end-stage renal failure, inflammation, pulmonary embolism, sepsis, and stroke. When diagnosis is not established following coronary angiography, Minoca represents working diagnosis as opposed to final diagnosis. It is vital for clinician to perform further assessment and investigation to establish underlying cause of Minoca, which will allow the final diagnosis to be established and patient be managed appropriately. Failure to identify the underlying cause of Minoca may result in inadequate and inappropriate therapy. So, invasive coronary angiography is recommended definitive diagnostic test for ECS patient. If underlying cause of Minoca is not established using ICA alone, further evaluation using left ventriculography, functional assessment with measurement of microvascular function, coronary reactivity, and intravascular imaging can be useful to identify underlying cause. The term functional coronary angiography refers to the combination of coronary angiography with adjunctive test. Now, assessment to be considered is first step is CAT assessment, that is clinical history, physical examination, and ECG finding. Then step two is ward assessment, that is in the ward assessment to be considered is clinical history, physical examination, ECG assessment, echocardiography, then cardiac MRI, blood test. And then post discharge, where patient need to do follow up, repeat echocardiography, repeat cardiac MRI, and cardiac rehabilitation. If underlying cause of Minoca is not established using functional coronary angiography, then non-invasive imaging is recommended. CMR is one of the key diagnostic tools to determine underlying cause of Minoca. CMR can identify the underlying cause in 87% of patients with working diagnosis of Minoca and should be performed as soon as possible after presentation in this patient to maximize its diagnostic yield and ideally during index admission. Now, recommendation for myocardial infarction. Now, recommendation for Minoca. In patient with working diagnosis of Minoca, CMR imaging is recommended after invasive angiography if final diagnosis is not clear. Management of Minoca according to final established underlying diagnosis is recommended consistent with appropriate disease specific guidelines. In all patients with initial working diagnosis of Minoca, it is recommended to follow diagnostic algorithm to determine underlying final cause. Now, the special situation, that is type 2 MI and myocardial injury. Pathological process other than atherosclerosis commonly underline the presentation of patient with acute chest pain with troponin elevation. These include type 2 MI and myocardial injury as defined in uh, fourth universal definition of MI. Type 2 MI is the ischemic myocardial injury in the context of mismatch between oxygen supply and demand that is not related to acute coronary thrombosis. This may occur in the context of atherosclerosis and oxygen supply demand imbalance, and with oxygen supply demand imbalance alone, secondary to vasospasm, coronary microvascular dysfunction, secondary to the non-atherosclerotic coronary dissection. The cause of type 2 MI can be divided to those with underlying coronary or non-coronary mechanism. Coronary mechanism include coronary embolus, dissection, spasm, microvascular dysfunction. Non-coronary mechanism include supply-demand mismatch due to hypoxia, hypotension, anemia, tachycardia, and bradycardia. Type 2 MI is common and associated with prognosis similar to type 1. Myocardial injury is characterized by myocyte necrosis and troponin elevation due to mechanism other than myocardial ischemia and can be acute. That is sepsis, myocarditis, Takotsubo. It can be chronic, which is related to heart failure, cardiomyopathy, severe valve disease. Myocardial injury is increasingly appreciated in the era of high sensitivity cardiac troponin assay, which is not specific for MI. In patients who have elevated high sensitivity cardiac troponin value and do not have evidence of acute myocardial ischemia, the diagnosis of myocardial injury can be made. It is important to recognize that this diagnosis can change if subsequent investigation indicate that patient meets the criteria for MI. Once the patient with suspected type 2 MI and myocardial injury have been stabilized and any precipitating illness have been treated, targeted echocardiography and coronary angiography can be used to identify contributory cardiac condition and to guide appropriate long-term cardiovascular treatment. Due to lack of robust scientific evidence investigating management strategy and the wide range of precipitating causes, there are currently no specific recommended pharmacological intervention for patients with type 2 MI. Therefore, management should instead focus on identifying and treating any precipitating condition alongside strict control of CV cardiovascular risk factors. Now, regarding complication, acute heart failure may occur as a complication of ACS. Acute heart failure as a result of ACS significantly increase risk of other in-hospital complications, including worsening renal function, respiratory failure, pneumonia, and death. Patients with ACS and acute heart failure are more likely to present with resting dyspnea, clinical signs and symptoms of fluid overload. In some clinical scenario, increased troponin level in patients with acute heart failure may reflect myocardial injury due to heart failure rather than myocardial necrosis due to ischemia. Mechanical complication may occur in first days following MI, most commonly patient presenting with STEMI. The incidence of mechanical complication has fallen significantly in the area of PC. Mechanical complications are life-threatening and therefore require prompt identification and management. Sudden hypotension, recurrent chest pain, new cardiac murmur suggestive of acute myocardial regurgitation, VSD, pulmonary congestion, and jugular venous distension raise the suspicion of mechanical complication. Immediate echocardiographic assessment is indicated when mechanical complication is suspected. Surgery is currently regarded as a treatment of choice for patients with ACS and mechanical complication, although percutaneous strategies are occasionally used in selected candidates with the prohibitive risk factor and contraindication to surgical approach. Patients with ACS-related mechanical complication should be considered for IABP while awaiting surgery. Now, the left ventricular thrombus. With the incidence of LV thrombus following AMI has declined due to advances in reperfusion and antithrombotic therapies. It remains relatively common, particularly following anterior STEMI, where it can present in more than 9% of patients according to large meta-analysis. Echocardiography remains the first-line imaging test for detection of LV thrombus. In patients where apex is not visualized on regular echocardiography, contrast echocardiography may be considered for improved image quality. CMR is the gold standard imaging modality for diagnosis and assessment of LV thrombus. Once LV thrombus is diagnosed, the OIC therapy, that is warfarin and NOAC, should be considered for 3 to 6 months, guided by repeated echocardiography or CMR, with consideration of bleeding risk and need for concomitant antiplatelet therapy. Now, the post-acute coronary syndrome pericarditis. Pericardial complications that may develop after AMI include early infarctive pericarditis, late pericarditis, and post-cardiac injury syndrome, typically occurring 1 to 2 weeks after AMI and pericardial effusion. Now, arrhythmia. Atrial fibrillation. Atrial fibrillation is the most frequent supraventricular arrhythmia. Patients with the AF have the greatest number of comorbidities compared to the patient without AF. Prompt treatment is required for AF causing acute hemodynamic state instability and electrical cardioversion being the preferred approach. Acute rate control can be achieved by administration of beta blocker depending on presence of heart failure and low ejection fraction. For patients with the depressed ejection fraction, amiodarone and digoxin could be preferred. In patients with hypotension, digoxin is preferred over amiodarone and beta blocker. In patients with the atrial fibrillation risk factor for thromboembolism should be adequately treated with chronic oral anticoagulation. Ventricular arrhythmia with the widespread increased uptake of emergency reperfusion, therapies for patients with STEMI, the incidence of malignant arrhythmia has significantly declined. The typical arrhythmia presentation is unstable, frequently polymorphic, and relatively fast VT, often degenerating into ventricular fibrillation. Urgent reperfusion is most important as ischemia is often triggered for this arrhythmia. Early administration of IV and oral beta blocker reduces the incidence of malignant arrhythmia. Beta blocker or amiodarone are recommended if malignant arrhythmia occur, and lignocaine may be considered if these are contraindicated. The prognostic role of early VT-VF within the first 48 hours of STEMI is still controversial. Several studies have suggested that patients with early VT and VF have increased 30-day mortality, but no increasing long-term arrhythmic risk. Another study has suggested that while malignant ventricular arrhythmia occurring at the time of reperfusion do not confer poor prognosis. Sustained VT and VF occurring during ongoing ischemia late after reperfusion is associated with increased long-term mortality. Sustained VT and VF after reperfusion, that is more than 48 hours, require evaluation of ICD implantation for secondary prevention of sudden cardiac death. Ventricular premature beats are very frequent during first 24 hours after reperfusion for STEMI, and no additional therapy is required. Some patients may develop electrical storm and the incessant VT despite complete revascularization and treatment with antiarrhythmic drug. So overdrive stimulation may help to control this situation. However, recurrence of VT and VF upon cessation of stimulation is frequent, and catheter ablation of such a trigger appear to be preferred treatment option in center with that expertise. Successful radiofrequency ablation has been shown to abolish the recurrent VT and VF. Non-sustained monomorphic VT is the common form of ventricular arrhythmia in early phase of ACS and usually does not require antiarrhythmic treatment. Accelerated idioventricular rhythm at presentation is frequent and does not require intervention given its benign nature. Bleeding is associated with poor prognosis. The mechanism by which bleeding increases the risk of death is complex and multiple. While intracranial and massive hemorrhage directly threaten life through fatal brain damage and sudden cardiocirculatory collapse, other less severe form of hemorrhage may increase the risk of death through indirect mechanisms. Blood transfusion may increase systemic inflammation and represent one of the possible links between bleeding and subsequent mortality. Bleeding is also a major driver for unplanned DAPT discontinuation and interruption of other medication. So, recommendation for acute coronary syndrome complications. So, IBP regarding heart failure, IBP should be considered in patient with hemodynamic instability and cardiogenic shock due to ACS related complications. Regarding LV thrombus, CMR imaging should be considered in patients with equivocal electrographic image in case of high suspicion of LV thrombus. Oral anticoagulation therapy should be considered for 3 to 6 months in patients with confirmed LV thrombus. Following acute anterior MI, contrast echocardiogram should be considered for detection of LV thrombus if apex is not well visualized on echo. Regarding atrial fibrillation, intravenous beta blocker is recommended when rate control is needed in the absence of acute heart failure or hypotension. Intravenous amiodarone is recommended when the rate control is needed in the presence of acute heart failure and no hypotension. Immediate electrical cardioversion is recommended in patients with ACS and hemodynamic instability when adequate rate control cannot be achieved promptly with pharmacological agent. Intravenous amiodarone is recommended to facilitate electrical cardioversion and decrease risk for early recurrence of AF after electrical cardioversion is unstable in recent onset AF. In patient with the documented de novo AF during acute phase ACS, long-term oral anticoagulation should be considered depending on the CHAD-VAS score after taking HAS-PLEAD score, the need for concomitant antiplatelet therapy into consideration. NOACs are preferred. Regarding ventricular arrhythmia, ICD therapy is recommended to reduce the sudden cardiac death in patients with symptomatic heart failure and ejection fraction of less than or equal to 35, despite optimal therapy for more than 3 months and at least 6 weeks after MI, who are expected to survive for at least 1 year with the good functional status. Intravenous beta blocker and amiodarone treatment is recommended for patients with polymorphic VT and VF. Prompt and the complete revascularization is recommended to treat myocardial ischemia that may be present in patients with the recurrent VT and VF. Transvenous catheter pacing termination or overdrive pacing should be considered if VT cannot be controlled by repeated electrical cardioversion. Radiofrequency catheter ablation at specialized ablation center followed by ICD implantation should be considered in patients with recurrent VT-BF and electrical storm despite complete revascularization and optimal medical therapy. Treatment of recurrent VT with hemodynamic relevance with lignocaine may be considered if beta blocker, amiodarone, and overdrive stimulation are not effective. In patients with recurrent life-threatening ventricular arrhythmia, sedation or general anesthesia to reduce sympathetic drive may be considered. ICD implantation or the temporary use of the wearable cardioverter defibrillator may be considered less than 40 days after MI in selected patients. That is incomplete revascularization, pre-existing LV ejection fraction dysfunction, occurrence of arrhythmia more than 48 hours after STEMI onset, polymorphic VT and VF. Treatment of asymptomatic and hemodynamically irrelevant ventricular arrhythmia with antiarrhythmic drug is not recommended. Now, regarding bradyarrhythmia, in case of sinus bradycardia with hemodynamic intolerance, high degree AV block without stable escape rhythm, IV positive chronotropic medication, that is adrenaline, vasopressin, and atropine, is recommended. Temporary pacing is recommended in case of failure to respond atropine. Urgent angiography with the view to revascularization is recommended if patient has not received previous reperfusion therapy. Implantation of permanent pacemaker is recommended with high degree AV block and does not resolve within the waiting period of at least 5 days after MI. In selected patient with high degree AV block, in the context of anterior wall MI and acute heart failure, early device implantation may be considered. Pacing is not recommended if high degree AV block resolves after revascularization or spontaneous. Thank you, guys.